So in my talk, I will give a little bit of a more generic introduction and focus a little bit more on the topic of ADHD. But the reason for that is that I want to sketch a little bit the long and winding road I think that neurofeedback has gone through, and also illustrate a couple of the methodological issues that we might be faced with in general, and then end off with the transdiagnostic aspect where I think neurofeedback, at least some forms of neurofeedback, could become instrumental to some degree in the treatment of tinnitus as well. So bear with me a little while before we get to the real topic of tinnitus, but I think it's probably a relevant introduction to understand some of the backgrounds. So these are the disclosures. I think nothing very significant related to neurofeedback at this point in time, but mostly TMS. So when we talk about neurofeedback, and I think for those of you who are not too familiar with it, I think neurofeedback can be likened very much to an operant conditioning procedure. And I think in the right bottom corner, we can see Skinner's pigeons. And I think most of you might have heard about it, where Skinner, who is basically the founding father of operant conditioning, was able to teach pigeons all kinds of tricks. It even went so complex that he could teach pigeons to play soccer or football. So those are not types of behavior that are part of a natural repertoire of a pigeon, but by rewarding successive approximations, you can teach pigeons very complicated behavior that they would normally not engage in. So this rewarding of successive approximations is a procedure quite similar that we want to do in neurofeedback. But in neurofeedback, we replace the observable behavior by brain activity that we can measure using the EEG, for example. And here we see, for example, an example of EEG, where we can see a kind of low voltage background, but here in the middle we see a kind of oscillation or a spindle, if you will. This could be, for example, an example of sensory motor rhythm. And in this case, basically what we want to teach an individual is to produce more of this specific rhythm, this 12 to 15 hertz rhythm, by giving them a reinforcement or a reward. Well, every time this type of an EEG oscillation occurs, and when the EEG will show none of this oscillation, we will not provide feedback. And so in the core essence, that is really the core of what neurofeedback is aiming to do. We're trying to modulate very specific brain activity. And for those of you who think that's the most often heard question when people engage in neurofeedback. So, well, tell me, what do I need to do? And then the best instruction actually, and there's research backing that up, the best instruction to give people is just do it. And I always tell people, if I could tell you what to do to induce that oscillation, then psychotherapy would probably be sufficient. But that's, I think, the real power of neurofeedback, that we really tap into neurophysiology straight away. And we know for a fact that EEG is not very well related to behavior, at least in the words that we use to express it. And there's no signature for depression or ADHD or tinnitus to be found in the brain, although the EEG can tell us a lot about future response to a treatment, which I think is a completely separate topic. So the kind of feedback that we see is it can consist of this very simple bar graph feedback, that whenever the activity exceeds the bar graph, then the subject will get a reinforcer with an auditory stimulus and also some visual feedback. And in some other forms of neurofeedback, for example, slow cortical potential neurofeedback, basically they have a fish swimming across the pond. And if the fish is swimming in the right direction, on the upper part or the lower part, then they get a reinforcement if they succeed well enough. And so there's various ways of implementing it. One very important thing I always tell people is that this is about teaching someone. This is not about entertainment. Why am I stressing this? Because many of the applications in neurofeedback, very often people start to entertain people and have very sophisticated games, but very often we see that a learning process cannot be engaged in. And that's also why I always emphasize people to think about the pigeon. If you have a feedback that's so complicated that the pigeon cannot extract the information from it, then very likely your child or patient will not be able to extract that as well. Because conditioning brain activity is already a very complicated thing to grasp by the individual. So I hope that provides a little bit of the backdrop of what neurofeedback actually consists of. As I implied with the title, it has a long and rich history. And for those of you unfamiliar with the EEG was actually discovered by Hans Berger in 1929. And what we see here is Alfred Lee Loomis. It's a very interesting character. And already in 1935, he was one of the few people across the ocean in the US that started replicating the work of Hans Berger. So that was only 6 years after the discovery. And of course, he could not have picked it up from the internet. So I think that's really a swift kind of way of having picked that up. What we've known by the EEG at that point in time is that when you close your eyes, there's a lot of oscillatory activity in the back of your head, your visual cortex. And when you open your eyes, it will desynchronize. So this tells you that your visual cortex is processing the visual information that pops in. And when you close your eyes, it starts to write in an idling mode again. So this was already described at that time. And what Alfred Lee Loomis here already described is that they used a light switch to switch on and switch off the light. And they already found that when they switched off the light, you can imagine that to be an eyes closed condition, you see alpha. And when you then switch on the light, that could be similar to this, then your alpha activity desynchronizes like here. At some point in time, they found out that only the switching of the light or the sound the light switch made could already result in these types of changes as well. And so a first example in 1935 that brain activity can be conditioned and brought under control. In this case, it was still classical conditioning, but it could be brought under conditioning control. It took a little bit longer before I think a more clinical topic was addressed, and we'll talk a little bit more about this later. But this is Barry Sturman without a beard at that point in time. Most people have only seen him with a beard. And this is one of his real early pictures with the original EEG equipment that we now have in a very small box and not as big as we see it here. And he basically, in a very accidental way, discovered that when he was operantly conditioning animals to produce the SMR rhythm that we see on the bottom, he was basically interested in like, well, what is the behavior that goes along with it? So he conditioned a group of animals to demonstrate that activity, and another group of animals showed he taught a different type of EEG activity. Then basically at that point in time, the NASA was in a kind of space race with the Russians, who is going to put a man on the moon as the first. And they also had rocket fuel, monomethylhydrazine, that was causing seizures in many astronauts. And he was asked to investigate it. And by accident, he found out that when he was exposing these animals, these cats, to monomethylhydrazine, that normally it would result in a seizure. And that happened indeed with most of the people. But the time it took to develop a seizure in the SMR conditioned group was very much extended. And in some animals, a seizure would not occur at all. And so this was really a first bridge where he was applying operant conditioning principles to SMR activity. And at the same time, he also observed that there could be clinical benefit associated to it, in this case for epilepsy. And that's also why where the field of neurofeedback started to be further developed, in this case, in the treatment of ADHD. So just to orient you a little bit, because I think there's a lot of good and bad and ugly, I think, in the field of neurofeedback. But this is, I think, to orient you to what we would consider standard neurofeedback protocols. And standard neurofeedback protocols are grounded in psychophysiology, and they make sense, and they have a good scientific backing behind it as well. And we see that slow cortical potentials, we will not talk about too much about it today, but they were first already described in 1966. In 1969, as I just demonstrated, SMR was first described, and a little bit later, the theta-beta ratio neurofeedback was trialed in ADHD in 1976. So let's first zoom in a little bit on theta-beta neurofeedback. So this is when we talk about standard neurofeedback protocols, they are defined by the frequency that we train, but also implicitly by the location where we train them. Theta-beta ratio neurofeedback is mostly comprised to frontal central regions. Slow cortical potential neurofeedback is comprised to CZ, And sensory motor rhythm neurofeedback is comprised to C3, CZ, C4, because that's where the sensory motor strip is actually localized. And so if you would train this rhythm in the prefrontal cortex, it would not be a standard protocol because that's not picking up the sensory motor rhythm. And so it's important to look at the literature with these glasses on, I would say. So we've published several meta-analyses, and again, there was a lack in the past of double-blind placebo-controlled studies. So when we simply look at pre-post treatment outcomes, evaluating what is the strength of the therapy, then in ADHD overall, we see that the clinical benefit for standard protocols is quite comparable to Ritalin for inattention and impulsivity, whereas for hyperactivity, it was a little bit below the effects that you would expect for Ritalin. And so far, that looks quite interesting. Then most interestingly, when we look at the long-term benefits, so here we look at the acute treatment effects in gray, and in white, we see the treatment effects after 6 months follow-up where nothing happened in the meantime. And these are the semi-active controls, and these are the active controls, mostly methylphenidate or Ritalin in the treatment of ADHD. And we can see that there's a significant benefit of neurofeedback on the domain of inattention, as well as hyperactivity, impulsivity. And there's a tendency for the effect sizes to improve further with time. And I think that's very important because with medication, you see the opposite trend very often. And so I think promising pre to post treatment effect sizes for overall neurofeedback, merging these 3 different protocols. So let's now zoom in a little bit more onto the theta-beta protocol. The main reason I would like to focus on this one, and I think this we need to see a bit more conceptually, because I think this is the first well-conducted double-blind placebo-controlled study where we collected 140 kids with ADHD. We pre-selected them on a biomarker. They needed to have a high theta-beta ratio because that was also what we were training. And we modeled this whole study after the MTA, NIMH-MTA study that also investigated behavioral therapy and Ritalin in the treatment of ADHD. And our main focus was on the long term. We were really interested to see if you would do a one-time, very intensive treatment procedure like neurofeedback, what will be the benefits after 1 and after 2 years? Well, the first answer is all kids and parents were blinded until the 25th month follow-up, and blinding was excellent. So there was no real unblinding going on. What we also see is that the acute effects, and here we see inattention rated by teachers as well as parents, and here we see parent ratings only. The reason I'm stressing it is because in the longer term follow-up, of course, parent ratings are more reliable because the teachers will change during the follow-up. The very good news we see is that the acute effect from pre to post treatment is showing a massive reduction in symptoms of inattention with an effect size of 1.5. For those of you not familiar with effect sizes, antidepressants in depression have an effect size of 0.3. And so 1.5 is a massive change in behavior. Unfortunately, what we saw is that both the neurofeedback group as well as the control group, and the control group actually comprised that we played back an EEG from someone else. So we call this a yoked control, and basically provided neurofeedback on that, where both the therapist as well as the child were blind to if it was a real or a yoked EEG feedback. So interestingly, and this was a multimodal treatment because it incorporated aspects like focus on sleep, focus on diet, but we see a huge effect size there as well. So we did a lot of good to many people, but unfortunately, we could not find a significant difference between neurofeedback and the control, although numerically it tended to be like that. What's even more interestingly, and this is what's currently, it will be published any day now in JCAP, when we look at the 2-year follow-up results, we see that all the results are maintained across time, both when it's parent-teacher rated, but also when it's by parent ratings. Although you might think there's a small difference here, it is not statistically significant. When the only thing that we found to be significant is when you look at medication uptake, the amount of Ritalin or other medications they would take, that was significantly lower in the neurofeedback group. But of course, that was not the primary outcome of the study. Then if we compare this study to what I mentioned, the MTA study, which is the largest study looking at medication treatment in ADHD and behavioral treatment, then we can pretty much see that although Ritalin has a slightly stronger short-term effect, that in the longer term, we see the effects are identical to neurofeedback, and the effects of the control group are pretty much identical and following the trajectory of the behavioral treatment arm of the MTA. So I think this is a very important picture. On the one hand, from a clinical perspective, and when you are a parent of a child with ADHD, I would think this is great. You do a one-time intensive treatment. You will notice that the likelihood of medication uptake will be lower, and the long-term benefit is at least equal to Ritalin. Now, I swap my hats and I put on a very critical note, and this is what many researchers and critics will say, like, well, you see, there's no difference between the control and neurofeedback, so this is all placebo. While both arguments can be valid, I tend to like the clinical aspect a bit more, because in the end, we are dealing with patients that have complaints, and we can treat them with a non-pharmacological approach, and at least it's no worse than what you would get with Ritalin. And if we call the neurofeedback effects all placebo, then, well, what do we say about Ritalin in this whole picture here? What it does tell us is neurofeedback really only about the control of brain activity, or is neurofeedback maybe a multimodal procedure that we need to focus on? And I think that's really the question that we need to ask ourselves. What is the active ingredient? And for the same reason that back in the 80s, we thought that the active component of SSRIs was serotonin, and we know now that serotonin has got nothing to do with it. We need to separate what is the working mechanism, and is there clinical effectiveness of a treatment? And so that's the important thing I want to stress and emphasize, because I could imagine similar issues coming up with the research in tinnitus as well. It's very important to design a good control condition. All right, let's switch gears to, I see I have 5 minutes left, so I need to speed up a bit. Let's now shift gears a little bit to the sensory motor rhythm neurofeedback, which I think is a bit more interesting, because interestingly, we cannot generalize the results I just presented, which is theta beta neurofeedback, to other forms of neurofeedback. So for sensory motor rhythm neurofeedback, I think there's a little bit more specific evidence. Previously, I showed you in 1969 that this rhythm was already trained and was found to have anticonvulsant properties. But only a year later, Barry Sturman published in Science this study where the same animals that were trained during wakefulness on this 12 to 15 hertz rhythm, when he let them fall asleep, he then looked at the EEG again. And what he found was that they showed more sleep spindles when they were trying to fall asleep. And a sleep spindle looks like this. Here we see the polysomnography during the night. And sleep spindles are picked up at C3 or C4, and they look like this. And when you look at the frequency, you will find out that the frequency of a sleep spindle is 12 to 15 hertz. And to cut a long story short, when you ask a polysomnographer or a sleep specialist, well, what do sleep spindles mean? Well, the more you produce while trying to fall asleep, the better you will fall asleep. And here in a controlled setting, he was able to show that when you train SMR, the sleep spindles go up and they remain elevated. And when you do the opposite training, it can actually diminish the number of sleep spindles. And this is also replicated in humans in 2008. So this is, for example, a patient with ADHD, and we very often look at actigraphy. And here we see a very disordered sleep where there was a lot of wakefulness during a first night, and the child supposedly was only sleeping for 4 nights. Do 25 sessions of SMR neurofeedback, we see that sleep is completely normalized. So the question we need to ask here, is it the sleep problems that were causing the inattention impulsivity, or have we actually treated the underlying ADHD as a separate phenomenon? And for those of you who know a little bit of research, I'm a big proponent of, at least in some cases or many cases with ADHD, that the sleep problem is actually causing the behavior that we label as ADHD. And if you treat the underlying sleep disorder, then many of the symptoms might go away as well. And that's still what I think is going on today. In this study, we actually demonstrated it, and we can see that the sleep normalization from beginning of treatment to halfway was significantly associated with the improvement on inattention. And that was not true for theta beta neurofeedback. And so this is a so-called mediator moderator analysis that will tell you how the causality is lying. These are two studies. This was an original controlled study from the University of Brussels, where they randomized to muscle tension biofeedback or SMR neurofeedback. And only in the SMR neurofeedback group, they saw an increase in total sleep time, polysomnographically determined, of about 44 minutes. And I think on a group level, it's a tremendous improvement in patients with insomnia. So these were not patients with ADHD, but insomnia. Then in a recent study, there was a French company that developed this portable headset combined with an iPhone app. Unfortunately, this is now discontinued, but I think this was showing quite promising results as well, at least on subjective sleep parameters as well, in people with sleep complaints. So summarizing this, I think, and this is a more extensive model where we see how the circadian pathways and circadian modulation taps into a vigilance regulation network, but also we know that neurofeedback can specifically impact on this network by training the sleep spindle neural circuitry, which we know is a reticular thalamocortical network. By training this rhythm, what fires together wires together, and therefore when this needs to become active in the future, for example, during sleep, people will have more sustained and solid sleep. And so I think it's a very powerful potential treatment for very specific sleep disorders. So now, how about tinnitus? Well, with tinnitus, and I think here, therefore, we really have to view this as a transdiagnostic feature. And for those interested, if you go to this URL, you can download the article that we published on it, where we position sleep and circadian factors as a transdiagnostic feature, cutting across many aspects in psychiatry, but potentially also neurology. And what we do know, and again, I've not extensively reviewed it, but we do know that there's many disruptions of sleep in tinnitus. In this study, for example, they found a lack of stage 3-4, that's deep sleep, but also a lack of REM sleep in tinnitus. And so we know many of the sleep aspects are disordered, and knowing that maybe tinnitus is a disrupted neuroplastic process, neuroplasticity is something that's tremendously enhanced by getting sufficient and a good amount of sleep. We also know that melatonin, that supposedly could have some potential impact on the circadian system and lead to more sustained sleep, as a treatment in several studies has shown an effect size of 0.3. It's not huge, but there could be a modifying factor of normalizing sleep in patients with tinnitus to at least have some benefit. And maybe on top of that, if you do a neuroplasticity treatment like TMS or like neurofeedback, there's no harm in at least trying to normalize sleep. And so addressing sleep, sleep hygiene, cognitive behavior therapy for insomnia, using actigraphy, light therapy, I think are really first-line suggestions to accommodate. If you really want to engage in SMR neurofeedback, I would first have really tried all these more cost-effective metrics, but maybe SMR neurofeedback could be an option there as well. We have seen several patients with tinnitus, and for them, when we applied the SMR neurofeedback, it really has made a clinically relevant improvement in their life. The tinnitus itself was not primarily impacted, but the way they could deal with it was quite significantly enhanced. Again, these are just case stories, but I think potentially promising, but especially having more focus on normalizing sleep. With that, I hope I've shown you the long and winding history of neurofeedback. The specific effect of theta beta neurofeedback is lacking, but the multifactorial nature is equally effective as long-term methylphenidate. It cannot be generalized to other protocols. I think SMR still, until a large controlled study shows the opposite, in my view, still has specific effects that are mediated via sleep spindles. And I think sleep as a transdiagnostic feature is a promising strategy for tinnitus. And now for the specific effects of neurofeedback and tinnitus, I think Martijn will provide us more details about that. I would like to also acknowledge all the people in the research group that we work with, and especially in this case, the ICANN team here in 2014, here in 2018, when we unblinded the study, which has been a tremendous effort and we learned a lot from that whole study.